Hi, my name is Mindy Udell, and I'm one of the faculty at Central Washington Family Medicine. I was asked today to talk a little bit about psychosocial medicine and the impact that it has had on my career as a family medicine physician. I was privileged to be one of the first residents that was able to rotate with Kirk Strassel on my ambulatory family medicine and psychosocial medicine rotations. I have to say that as an intern, which is the first year of your residency, I was not super keen on psychosocial medicine and the fact that I was spending a rotation. I went to University of Washington. They had a pretty robust, what I felt, behavioral medicine that we spent several days a week practicing. I thought that I had really great skills being able to take a full history and to be able to integrate that into my plan. And I honestly was a little annoyed, is probably the word that I would use, that I used time that I could be spending learning about diabetes or hypertension, about stuff that I considered probably fluff. And I say that knowing that I also thought that I was pretty good at the fluff, because when you're an intern, you have an entire hour to be able to spend with a patient and be able to gather all of this history. And so going through my intern year, I thought, well, this is easy stuff, right? Like, I can do this. I really don't need you to take up a rotation. And I honestly considered it more vacation time, which sounds kind of harsh, but I did. But moving into your second year and your third year, you now have to see patients. You're now moving up to 6 patients, and then 8 patients, and then 12 patients, and you realize very quickly that you no longer have this wonderful, blessed hour to spend with a patient and to be able to ask them about their history. And the wonderful thing about family medicine and continuity is you also learn that even though you tell somebody to do something, or you think that you are planning a plan or making a plan together, you find that they come back and they did nothing that you asked or that you planned together, and you think, well, what the heck? And you start learning that it's because this was arranged around what my values are and what I want patients to do, and I didn't understand the art of really understanding why I need to understand the contextual interview and really what really is going on in my patient's life. I mean, I know that you smoke, and I know that you are having financial problems, but how do I actually take that and now imply that, or take that and make that part of my plan and change my plan so that it's something that you can actually do, not something that I think you can do, but something that you can actually do. And so over the course of my 3 years of residency, as you spend more and more time with patients and learning their lives, I realized that this is a lot more than fluff. It's actually the foundation. It's completely the foundation of everything that I need to do. And if I don't have a foundation, then everything else is going to fail.
Would you say that, you said that the experience kind of at the beginning was that sense of kind of annoyance and that I kind of know this already. Do you feel like that was kind of universal amongst your fellow?
Oh, yes.
Yeah?
Oh,
okay.
Yeah.
Okay. All right. Good to know. All right.